It may be the biggest disruption to healthcare since the COVID-19 pandemic. Between 4 and 20 million people are projected to lose their healthcare coverage during the process called Medicaid redetermination. Millions of people who've had Medicaid for some or all of the last 3 years will lose their coverage this year. Millions more will have their coverage interrupted as they apply for reinstatement or a different health plan. Who will be affected by Medicaid redetermination? What will it mean for their access to healthcare and ability to prevent and manage chronic conditions? When will it happen? Why will it affect healthcare providers and people who have commercial health insurance? How will it affect health equity? These questions will be answered by a panel of experts during this Value and Innovation Forum briefing. I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention and co-chair of the Value and Innovation Forum with Alan Balch of the Patient Advocate Foundation. We're pleased to welcome you to this briefing, and we thank Amgen, whose sponsorship makes it possible. The topic and speakers were chosen by a steering committee that includes Dr. Donnell Ivey of the Association of Black Cardiologists and Michael Bagel of the Alliance of Community Health Plans, in addition to Dr. Balch and me. To lead today's briefing, I am delighted to introduce the moderator, Julie Rovner. Ms. Rovner is the Chief Washington Correspondent for KFF Health News. Prior to joining KFF, she was NPR's Health Policy Correspondent for 16 years. Ms. Rovner is the author of the critically praised reference book, Healthcare Politics and Policy A to Z, now in its 3rd edition. In 2005, she was awarded the National Press Foundation's Everett McKinley Dirksen Award for Distinguished Reporting of Congress. Ms. Rovner.
Thank you so much for the kind introduction. And may I apologize in advance for the occasionally barking dog. I want to thank the Value and Innovation Forum for sponsoring this webinar. We have a terrific panel of experts here to share their expertise. Before we get started, I invite you all to participate in a poll that will appear on your screen. Please let us know if you're here as an advocate, public health professional, clinician, health system decision maker, health policy researcher, policymaker, journalist, or other. Give you guys a second to please vote. And while you're doing that, excuse me, I'm going to introduce our panelists. I'm going to give a brief summary of their bios. You can see their full bios on the Value and Innovation website. We're going to start with Jesse Baumgartner. He is Senior Research Associate in the Healthcare Coverage and Access and Tracking Health System Performance Program. Before joining the fund, he worked as a Technology Development Licensing Manager at Memorial Sloan Kettering Cancer Center, a Life Sciences Consultant at Stern Investor Relations, and earlier in his career as a reporter for the Lewiston Tribune in Idaho. Next is Jennifer Wagner. She is Director of Medicaid Eligibility and Enrollment at the Center on Budget and Policy Priorities. She focuses primarily on Medicaid eligibility and enrollment issues, including the policy, operations, and technology that affects the enrollment experience for clients and staff. She also coordinates with SNAP and TANF staff to analyze opportunities to improve access and advance coordination with Medicaid. Previously, Ms. Wagner served for 5 years as an associate director with the Illinois Department of with the Illinois Department of Human Services, where she oversaw SNAP and cash assistance policy, as well as the local offices throughout the state that determined eligibility for cash, SNAP, and medical assistance. Next is Thomas Pham, who is Vice President of Strategy at Inland Empire Health Plan. He leads the creation and implementation of IEHP's multi-year strategic plan and ensures the health of the entire strategy portfolio. And finally, we have Keith Churchwell, who's president of Yale New Haven Hospital and executive vice president of Yale New Haven Health. Before becoming president, he served as executive vice president and chief operations officer and senior vice president and executive director for heart and vascular services, transplantation services, and clinical service coordinator for the Department of Medicine at Yale New Haven Hospital. And I can't imagine that that ever was able to fit on a card. So here's how we're going to go ahead and do this. Each of our panelists is going to speak for 3 to 5 minutes. Then I get to ask questions. If you have a question you would like me to ask, and I am sure you do, please use the Q&A button on your Zoom bar rather than the chat. If you see a question you like, you can upvote it, and that will help us notice it. So we are ready to begin. First up is Jesse Baumgartner. The floor is yours.
And actually, we do also have the audience survey results up for a brief moment.
Start. And here are the audience survey results before we get underway.
There we go.
So now, Jesse, it is yours
Okay.
to speak.
Thanks so much, Julie. And thanks to John and Kina for organizing this event. It's obviously such an important topic, and we're excited to be here. Could we go to the next slide, John? Terrific. So I'm just going to briefly touch on some research that we put out at the Commonwealth Fund in March, and just kind of try and set up Jennifer a little bit on just what has happened on coverage trends during the pandemic. This particular report looked at what was happening with coverage inequities over a longer time span, but I'm going to kind of focus in on the 2019 to 2021 timeframe to just set the kind of stage for what we're talking about today. So as we can see here, since the Affordable Care Act was passed, there's been striking narrowing of inequities in health insurance coverage between white and Black and Hispanic adults. We looked at adults specifically in this report. You can see we've circled the 2019 to 2021 period, and we actually saw narrowing or rather improvements in coverage for all of those groups during that time, sort of despite the disruptions in the pandemic, so across the board. Next slide, John. And then if you look at specifically in that 2019 to 2021 period, and kind of bringing us back to the topic of today's conversation, the role of Medicaid, we can see really what happened during the pandemic, and this is true really across all of the 3 racial and ethnic groups that we looked at, was you saw a bit of a drop in employer coverage, a little bit of a disruption there, but a real increase of about a percentage point across the board and more for Black and Hispanic adults in Medicaid coverage, increases in individual such as marketplace coverage, and then the overall effect being an actual dropping of the uninsured rate during that time, again, despite the real disruption to the healthcare system during COVID. And then if we go to the next slide, John, we're just showing here that this same trend occurred across both Medicaid expansion and non-expansion states. There's a little bit of a difference in how it happened, a little more Medicaid coverage growth in expansion states, a little more individual coverage growth in non-expansion states. But again, the overall effect, lowering the uninsured rate for all 3 groups, actually narrowing the disparity even a little more between white and Hispanic adults. And so we can really see kind of what a critical factor Medicaid was during this period in terms of maintaining coverage levels, improving them a little bit, and really because of the outsized impact it had for Black and Hispanic adults, really stopping disparities from widening further when they otherwise might have in the absence of some of the policy changes around Medicaid during that time. And then John, if we can just go to the last slide, just to kind of hand it over to Jennifer, as we think about the equity implications of the redeterminations, they're really large. What we're looking at on this slide is the insurance coverage sources for different racial and ethnic groups for adults. And what we really see here, particularly for Black, Hispanic adults, and American Indian Alaska Native adults, is a much larger percentage of that population covered by Medicaid. So when we think about all Medicaid applications being redetermined, again, this is not the same across the board. It is making up a larger percentage of certain groups, a large percent of the overall population, absolutely. But these are the type of equity implications that we need to think about as states are redetermining. And with that, I will hand it over to Jennifer or Julie.
I will hand it over to Jennifer. Jennifer, your turn.
Great, thank you all, and thank you so much for having me on this presentation. So I'm going to talk a little bit first about how we got here and what's happening as part of this big thing called the unwinding, and then talk a little bit about outcomes and what to expect coming forward. So how we got here is that in March of 2020, Congress passed a law that basically said, in exchange for enhanced federal funding, everyone had to be kept on Medicaid for the duration of the COVID-19 public health emergency. So we were watching the PHE very closely, and as you know, that ended last week. But Congress threw a little curveball in December of last year. They changed it from being linked to the public health emergency and set a date certain for the ending of the continuous coverage provision. So that ended in March of 2023, and now we're beginning this process called unwinding. That provision was very effective. We saw around a 30% increase in Medicaid enrollment. And as Jesse very helpfully outlined, we saw some differences across racial and ethnic groups and how that actually played out. So what's happening right now? This process called unwinding requires that everybody on Medicaid be subject to a renewal over the course of the next year. Now that's normal operations in Medicaid. People are usually renewed yearly, but that wasn't happening during the pandemic, or if people didn't complete their renewal during the pandemic, they didn't lose coverage. The good news is it's not happening all at once. States do have 12 to 14 months to complete this process. And so we'll be talking about this. We'll be looking at data. We'll be working on this through at least May of next year as states do go through this renewal process. But there's a really high risk that eligible people could lose coverage during this process. There always is at renewal, but it's an increased risk now because of the unprecedented situation we find ourselves in. People may have a lack of awareness of what's coming or an understanding. Some states sent out renewal notices during the pandemic, but if people didn't complete them, they didn't lose coverage. So people may not understand that now it's different. A lot of people moved during the pandemic, or it changes to their living situations or their family compositions. So they might not get a notice saying that they have to renew. And the states are sending out some really confusing notices and messages. This has always been a problem in programs like Medicaid, but we've got lawyers and experts trying to decipher these notices and figure out what the heck they mean. It's very difficult to navigate. Also on the state side, states are very understaffed. That's always been the case, but it's exceptional now. Not only are they allocated insufficient staffing to handle the workload that's coming their way, but they have a really high rate of vacancies. People are really having a hard time filling these positions. And some states that have recently staffed up have newer workers, many of whom have never done a renewal. So let's talk about what's going to happen to people as a result of this unwinding and renewal process. There are 4 big buckets that we're looking at. Some folks are eligible for Medicaid and they're going to stay on Medicaid. Great, they should be good to go. We've got another bucket of folks that are going to be ineligible for Medicaid, but they have access to other coverage. They may be eligible for subsidies on the marketplace. There, we've got to make sure they transition well. Just because they're eligible for these other sources of insurance doesn't mean they'll actually get connected to them. So we need on-the-ground assistance, good communication, et cetera. A third bucket is folks who are ineligible for Medicaid, but they're in the coverage gap. They're in non-expansion states, and they may be categorically ineligible for Medicaid or have income too high for Medicaid, but too low for marketplace coverage. That's a huge problem, more kind of a political than an operational solution, but we're going to be seeing that quite a bit. And the fourth bucket is the one that we're a little more focused on at CBPP. These are folks who remain eligible for Medicaid, but lose it, often due to procedural barriers, not receiving the notice, not understanding it, the agency not processing it timely. This is the big problem that we're going to see. And the estimates are that almost half of the folks who lose coverage will in fact remain eligible for Medicaid, but lose coverage due to this administrative churn. And we're going to see a higher proportion than average of children, as well as Latinos falling into this bucket. Now, the good news is states can do this well. Believe it or not, as complicated as it is, Medicaid is set up for streamlined eligibility determinations. States are actually required to check electronic data sources first before sending anyone paper renewal form to see if they can automatically renew them. Unfortunately, we have a large variance in how much states take advantage of this policy. There are a lot of best practices and innovation happening, like text messaging. Okay, that's not super innovative to the rest of us, but in this context that is innovative, we're seeing more states do this than ever before. Some states are doing communication campaigns with bus wraps and PSAs and billboards. Some are funding outreach so that folks in the community can meet people where they are in their language and with cultural competency and help them through this process. So states have the power to do this well, but it's hard and some aren't fully invested and things are getting in the way. So we've got some initial results that are coming in that are frankly pretty concerning. States could begin terminations as early as April 1st, and some won't start until July 1st. We had 5 states start in April and another 14 start in May. So we've got less than half of the states that have actually begun terminating coverage, but what we're seeing is lots and lots of procedural terminations. There's one bucket of folks who are found ineligible. You know, their income was too high, they no longer fit a categorical eligibility for Medicaid, but we're seeing tons of people just not returning their form. Some of those folks might know they're not eligible for Medicaid or not need it and choose not to send in their form. But we know there are a lot of people in that bucket who remain eligible, but again, didn't get it, didn't understand it, sent it in and got lost in the process somewhere. So that's something we're really keeping our eye on and watching to see how many of those folks likely were still eligible. We'll see by a high reapplication rate. Most people don't say, oh, I guess I don't need health coverage. Once they lose it, they come back in and reapply. We'll see people showing up at pharmacies, at provider appointments, and finding out there that they lost coverage. Lots of call center, legal aid inquiries. So we've got a lot of networks on the ground that are monitoring this feedback, and we're trying to kind of see where the problem is. Is it a state agency processing issue? Is it a communication and outreach issue? Or is it just kind of an awareness and complexity of the process issue? So that's going to vary a little bit by state, but we're keeping a close eye on that moving forward.
Great, that was a lot. I will say I'm here in Maryland, and last night I saw a television ad on the local news about, if you have Medicaid, here's what's going to happen. It was pretty easy to understand. Not sure how many people still watch the local news. Okay, now I'm going to turn it over to Thomas Pham.
All right, good morning, everyone, and thank you for having us today. And thank you, John and Julie, bringing us together to discuss this. I said, Medicaid redetermination is one of, I would say, the significant event in the Medicaid history. And Jen, listen to you, and I feel like we are breathing what you say every day here in California. I totally agree on the 4 bucket you discussed, and also the strategy that different, the state U and the health plan U as well. So with that, a little information about IEHP, Inland Empire Health Plan. So we are not-for-profit public health plan serving about 1.6 million residents in Riverside, San Bernardino County in California. Our 2 counties are the 2 largest county in the nation, geography-wise. It's spanning 27,000 miles in Southern California. And we are the top 10 largest Medicaid plan and the largest not-for-profit Medicare Medicaid plan in the country. So from the slide, you can see a little bit about our membership profile. So 98% of our members are Medicaid. So you can see the significant impact of Medicaid redetermination on our membership. Some breakdown of the age and ethnicity, 57% of our members are Hispanic. And you see 10% are African American, and 17% are Caucasian. So next slide. So given the significant impact of the Medicaid redetermination that Jen mentioned early on, that we forecast that about, for IHP, we about 200,000 to 300,000 of our members are at risk of losing coverage. So that put in the perspective of state of California, it could be about 2 to 3 million lives will be at risk of losing Medicaid coverage. So it's significant. It's a significant event. And like Jen mentioned that, the state of California and many health plans like us, we introduce a lot of innovative strategy and do something very different than we had done prior to the PHE unwinding period. So that including, number one, we partner very closely with our county Medicaid office. That is the key, because like Jen mentioned, not everybody have the same renewal month, right? So they have 12 different renewal months, and also not everybody have to fill out that renewal application, because the county will use the federal data hub and match the membership against the federal data hub, and whoever have a match and with the income plus minus 20% threshold level will automatically renew their eligibility. So in our county, about 40%, the early data, 40% have a successful match rate. So that means 40% are auto renew because of the match with the data hub. The other 60% receive a pre-renewal application. So with the partnership with our county that the county share with us every month, whose IHP member receive the manual renew application. That giving us ability to have more target outreach and personalized outreach. So with the significant impact IHP, we put a big investment. We put together a team of 50 eligibility specialists who know in and out Medicaid application, the renewal. So this team, we use the team to do an outbound call to those families and help them complete the renewal application right on the phone. So we go beyond the reminder, the awareness. We provide a hands-on renewal assistance to our member, completing an application. And early data show, on average per day, we help about 500 families complete their application on the phone. And beyond the direct outreach to our member, we have a massive strategic outreach and communication that targeting our member, that including the texting that Jen said. It's not innovative to us, but in a way, is really impact to our member, because when we send the text to our member, we're able to say, Ms. Garcia, your renewal is due in June. Would you like someone help you out? And if they say yes, and they can text back us the time and the date that we can outbound call and call those members. So we utilize that text. It's heavily from that perspective. And we send, the 60-day reminder, the 30-day reminder to the member who actually received the manual application. So we don't go like broader, like 1.6 million live, but we go to the individual who have the renewal coming up. So very targeted. And then we have alert set up in our system that when our member call, any call center at IHP, there will be alert pop up, and the member services or any care coordinator connect that member to our eligibility to do that. And also, on the provider side, that we set up alert on the eligibility portal as well. So when our patient walk in, and actually we turned on that yesterday, and we received significant call volume from provider community that our member are at the provider office and they calling in. They say, my provider telling me that I need to call you to complete the application, because we set an alert. So any member walking to our provider, they will check eligibility with IHP using our portal. So that alert pop up for that member. So that partnership is so significant, hopeful in impact the number of family that we help. And of course, we partner with the community, we share the toolkit, we do a town hall. So a lot of those activity going on to reach out to a broader population for this effort. All right.
Sorry, could not find the mute button. Finally, we're going to hear from Dr. Keith Churchwell. Before that, I want to remind people you can put your questions in the Q&A, and feel free to use the chat if you just want to chat or react. Dr. Churchwell, floor is yours.
Well, I'll just take a few minutes. Listening to our three great speakers, it reminds me that all this rolls downhill, and the major community hospitals and academic medical centers are actually going to be not the beneficiaries of this particular program, but also will have to deal with actually this patient population. The calculation is about over 20 million people actually are going to be at risk as of April 1st. And we are dealing with a tsunami of the decrease in overall reimbursement from Medicare from COVID, coupled with the loss of Medicaid for this patient population who gets their care actually within our particular environments, whether actually the community hospital and the acute care facilities, or the facilities actually are institutions like ours actually build and actually maintain and support for those patients who actually will not be seen in the community because they have Medicaid and need to get their care both from the ambulatory standpoint within our walls, or they won't get care at all. And this is in the setting of the fact that hospitals at this point are actually persistently have negative margins in regards to the overall cost structure since the beginning of the pandemic, and has only been exacerbated over the last year and a half, but not really an end in sight in terms of looking at overall cost structure. At this point, the math doesn't work. and leading to a significant decrease in the overall reimbursements, only going to make this particular situation worse. Our ability to expand programs to cover the needs for the patient population is going to be inhibited. Our ability to actually take care of these patients, not only in the acute situation, but also post their late leaving the hospital, which is key in terms of keeping them out of the hospital and making them healthier, is going to be significantly important. I think also important is actually going to squeeze our middle-class patients and their families to a greater degree. Those that actually have some degree of insurance, but actually marginal insurance, because of their outlay for their overall coverage is actually significant based upon their insurance plan. They're going to have to actually belly up to the bar to an even greater degree to cover their costs because of the stresses and strains that actually our institutions are having to deal with, because not having enough resources from a financial standpoint to cover those who are going to be lost in this particular situation. Now, there's a lot of work going on by centers like ours across the country in concert with institutions like that we've discussed over the last few minutes, in trying to prepare for and actually getting the word out to our patients of this was coming. And also when they come to the hospital, actually identifying those with the need and actually working towards helping them to evaluate, to actually fill out the paperwork and actually go forward. But that's going to take time. We could be a year down the road without having a significant improvement in the overall coverage of a very large patient population. And that's going to have a significant impact, obviously, in terms of the overall financial situation, health of our hospitals and our community centers. And that's going to trickle itself throughout the whole community of patients that we serve. So there is a tremendous amount of work to do from a redetermination standpoint to get us into a better place as we work on multiple issues from a cost standpoint and from a clinical standpoint in terms of the delivery of care.
Right. Well, thank you so much. I will remind you again to still offer up your own questions, but I have a whole list, so I'm going to jump right in. I know it's still early. Obviously, we only have a few states that are starting this, but what kind of processes have been implemented by states so far, and what are the results? Jennifer, you kind of touched on this already, but go a little bit deeper.
Sure. I think the best way to think about it is to look at the different steps in the process. The first is kind of the awareness. And as I mentioned, there are bus wraps. Some people have been doing outbound calls. And we can't say enough about the partnership that Thomas articulated with the managed care organizations. That is a huge opportunity. CMS has gone out of their way to make partnerships possible, to share information, to allow them to help state agencies that may not have the capacity or the flexibility to do things like texting and more active outreach. So people have to know what they have to do and when to expect it. The when is a big portion. It's a hard messaging thing to say, open your mail over the next year. You might get a notice at some point and hopefully you don't miss it, but wait, it might not be till November or January of next year. So some states are allowing people to call in and check their redetermination date. Little things like that can really give people more security and cut down on the calls of people calling in right now to say, I heard this is happening, what do I have to do? Then you look at the communication that people receive. What does that renewal notice look like? Some people are getting forms that say you have to renew, go online to get a renewal form. Some states aren't even sending a form. Sometimes they're sending too much of a form, 40 pages to fill out. So that aspect of the communication is a huge issue. Is it getting to the right place? Are states doing a good job using things like the U.S. Postal Service National Change of Address database, or updating information, pulling addresses from folks like MCOs to make sure it's getting to the right place? But what's really important is how somebody actually submits that form. Federal regulations do require that states accept renewals in person, over the phone, online, and by mail. The over the phone and online is where some states are falling behind. This has been a requirement for a decade, let me just say. Since HPA was implemented, this is not something new, but some states have not put in these pathways yet. And that's really important to make sure that people have options that meet their needs, whether they have internet access or not, and to make sure that those forms can get sent back. And then finally, it's about the state agency and how they are staffed, how they are organized in order to process these forms that come back. Also want to point out that about 39 states or so have some combination of integrated administration with programs like SNAP, food stamps. And so in these states, some of them are struggling right now before renewals start. They're behind in processing, they have long wait times. And so when you do have this tsunami of renewals and additional work coming the way, this unfortunately runs a risk of spilling over and affecting access to other programs like SNAP. So it's really important that states invest in those agencies for well-staffed processes, for efficient processes, and good customer service.
Jesse, do you have anything to add to this, or what you've seen and about what states are already doing?
No, I mean, maybe just that there are, there are 50 states and there are a lot of approaches out there. I think some organizations have done a nice job of capturing what different ones are doing, in terms of outreach or community meetings, or I think even some states have done listening tours. And then I might just highlight, there have been some other innovative state approaches. Oregon's one I would think of, where they actually applied for a waiver to actually cover a greater income eligibility group right out of the redetermination to try and minimize sort of the initial impact. Obviously that's a much more extensive process, but just in terms of kind of how creative states are getting, there's other pathways that some have considered like that as well.
I want to ask Thomas Pham and Dr. Churchwell, there's obviously going to be a big difference between states that want to keep people on Medicaid or other coverage and states that would just as soon not. So obviously providers, insurance companies, hospitals are going to have to play a role and have a self-interest in this. Have you heard about, I mean, obviously, they're in California and they're in Connecticut are states that I would think would want to keep people on the rolls. But have you heard from, other providers in other states who are going to jump in and perhaps do what the state isn't doing?
Well, that is exactly what's happening. There are a number of examples like Temple Health and Providence in Washington that actually saw this coming over a year ago and started to ramp up the number of individuals with expertise within their particular communities as navigators for patients so they can walk through the process. And, Nail-Native Health, we've had that for years. I just left a meeting this morning about population health and the need for us to actually invest more and more in individuals with expertise to align themselves and join patients along this journey, because it gets very complicated, even in the state of Connecticut. But actually, it is complicated in terms of with the forms you have to fill out, when and how, and what's the overall process. Because if we don't do that, we're not going to get paid. And the patients are going to lose coverage. And importantly, when they lose coverage, they stop going to the physician. It only takes that one visit when you're asked at the end of the visit, well, do you have your checkbook? And this is actually how much the visit is going to cost, and it's unexpected, and you don't have the coverage. The next time they're going to say, well, I'm going to the doctor. That's going to cost me money, and I feel okay, so maybe I can miss this appointment or not take this prescription or not have this test done. And that only leads to a higher degree of complexity, a more severe patient population who ultimately is going to need care and is going to have an even higher burden from a clinical standpoint and a financial standpoint to the overall system.
Hey, Julie, from California side, like Jen mentioned, I want to give shout out or kudos to our state leader on Department of Healthcare Services. Literally, they take advantage of all the flexibility the CMS given to the state, that including the use of NCOA, the National Aggregate of Change that Jen mentioned, that pre-PHE, that before we able to use that data, we have to contact the member and verify their move before we can use that data. And now we're able to use that, the county able to use that, so they can send the renewal packet right to that individual. The texting flexibility from we use that. The state use the threshold, increase the threshold percentage of deviation with the federal data hub. So before PHE, it's only plus minus 5%. And the flexibility now is plus and minus 20%. And then a bucket of population that Jen mentioned about that they no longer eligible because their income up. How do we capture them in that change? So the state introducing a legislation that allow those individual auto enroll in marketplace. So we follow the model very similar like Rhode Island has, that they share with us. So we share back with the state, and that's how we introduce that model. And flexibility of the state work with directly with the county. Now they learn the success model that IHP had with the county on the data exchange for the personalized renewal date. The state use that model and apply across the state for all counties. So now all county will have access to the renewal date for individual have to go through the manual renewal. So a lot of flexibility that our state that using that under the CMS directive on the flexibility side. So one comment on Dr. Chidwell about the relationship with the hospital is one of the key in our communication side. We work with all 36 hospitals in our network, and our CEO really send out a personalized letter to every hospital CEO, and we make a change in how our network works. So every single patient of IHP that walk into the hospital, the registration office will check the eligibility for that individual and see the alert. They're gonna give that member on phone number and ask that member to connect with us. So that is the key. And many of our hospitals already utilize that and connect the member to our call center.
Jennifer and Jesse, I mean, we've seen so much, about how to help the states with this process. Are there any best practices for providers and insurers for making sure that people who are eligible remain covered?
I think the key is to understand the process in your state and how you can help someone. Thomas, I think you're making everyone else jealous who doesn't live in California at the really strong partnership and the great things that you've got set up there, because those are really just great examples of the best practices and what can be done. So any information, I know that there are a lot of people who don't eat and breathe Medicaid all day who can really contribute to this process. So I would recommend to connect with navigators or sisters in your community or kind of the lead advocacy organization. Most states have one or a few organizations that are really doing this, and learn from them the processes. There's some key things about how you go. What's the website in your state for people to go? What's the phone number? Can you at least give people that information? There are key things like if you lost coverage, you actually have a 90-day reconsideration period, where if you reach out to the state during that period, you can just complete your renewal and don't have to fill out a whole application. If you have a state-based marketplace, what's a referral there, or to other folks in the community that can help through. So there's a couple of key pieces of information. You don't have to be, deep into all the nuances and complexity of Medicaid, but if you can give some people information, somewhere to go, a number to call, a website to look at, and just some basic information about what is happening and what they can do to maintain their coverage, that can go a long way in easing their fears and giving them kind of a plan of action.
Jesse, have you heard about other ways to reach out to insurers and providers?
Yeah, I was just, I don't have a ton more to add than Jennifer said, but I would just, again, point to some of the state innovations and the touch points. I think that's an important point. New York is one example that comes to mind that I read about recently, where they're stationing sisters in pharmacies where people might go, pick up prescriptions. Again, it's the provider or the parts of the delivery system that people might touch could be very different. And to the extent, I think Thomas and Dr. Church will touch on this too, the extent that you are not just doing it all in one place and you're seeing states kind of try to cover the range of kind of points that the people might enter the system and then get them to the connections that Jennifer was mentioning. So that's the only thing I would add.
So Julie,
go ahead.
Just a thought, and when we talk about providers and actually informing and educating them in terms of what's happening and how they can make an impact. And my concern with that, of course, is that providers are incredibly busy and working each and every day, probably at a very high stress level, and just trying to make sure patients get some degree of care. Adding the responsibility of actually helping patients navigate through this is not going to be a tenable solution to this particular problem, right? So it behooves us actually not only at the medical center perspective, but also at the city and state level to actually bring resources to bear who actually have that expertise and allow providers to do the work that they're actually supposed to do, as opposed to navigate the next pile of paperwork is going to be really important.
Yeah, and we have a follow-on question from the audience to just that point. So doctors and providers tend not to be versed with the ins and outs of both Medicaid and Medicare. How can providers learn more about the mechanics of the process, learn how to share information with patients, and learn how to advocate within their organizations, maybe to get help for people to do that so they don't have to? But that's for anybody.
Yeah, so I can start. Yeah, for us, we recognize provider the key, because end of the day, our member will get care from the provider. So we have, as we launched the communication and outreach program to the provider, we utilize all forums. So we have provider advisory committee. We have the dinner roundtable by region. So every month we have a dinner in that region, and we invite all the provider in our network come to that dinner, and we share the implication. And also, all communication from the email to letter to online portal. Core thing for us is that we work very closely with their support office, because we have a quarterly connection with the office staff, and we invite them to come to the whole plan, having, give them update, provide them education about the process and the toolkit that we give them so they can use for the redetermination. That toolkit including that train them how to use the provider portal to see the alert. We also provide the provider a roster of their patient who have the renewal for that month. And we make it very convenient for them, that very simple message and toolkit that they can mail to their patient as well. We developed that the letter for them, and they put their name and a co-branded letter, so it's from the provider to mail to the patient. And so we utilize all mode of communication, and so far that 50% of our call to the call center coming from the provider community. So we are super, super blessed and grateful for the partnership and the support from the provider community.
And now you're making me jealous that we're not all in California. We've talked so much about how this is impacting, obviously, the people who are on Medicaid and going to come off of Medicaid or going to transition to something else. How is this redetermination going to affect people who are not on Medicaid? I imagine, people think this has nothing to do with me, but this is going to be a big sort of shock to the entire healthcare system, right? That's for anybody.
Well, I'll give you a perspective from the hospital, I guess, and for a systems perspective. You're right. It is all going to go down, trickle downhill to those who actually are paying or can pay. We have moved more and more towards the responsibility for our patients and families to co-payment a process that there's a higher copay that actually they are responsible for to actually have what we call insurance. In a system where actually the overall cost of the system continues to increase, and we actually have less from a revenue standpoint, and we have a patient population that is not covered, and we have to bring coverage for it. The negotiations between a physician or a medical group or a hospital with an insurance carrier will lead to the fact that there's a greater need for the expense to be covered. So a greater need for revenue from that particular agency, and they're going to pass those costs on to those who actually are claimants in their system. So in actuality, it probably will lead to an increase in the amount of copay that a patient or family has to cover, which is going to increase the overall cost to them. So that's, I think, the unintended and trickle down effect. If we don't move towards a more rigorous and structured system of actually making sure these 20 million people have some degree of coverage.
Anybody else?
I might just add, Jennifer touched on the Medicaid coverage gap before, but when you think about, the potential increase in uninsured rates in non-expansion states, many of which were already having issues around financial strength of rural hospitals. And so when you think about that potentially exacerbating that, states like Mississippi and North Carolina, obviously they're thinking, more strongly now about expansion, but those are already states where 30 to 50% of rural hospitals were struggling financially. And this has the potential to exacerbate that if a financing source is getting removed.
Right. And I mean, as we're seeing all over, as these hospitals close, it's clearly not just the people on Medicaid. It's everybody in that community who's impacted. I want to ask about equity, because that's obviously an important issue for everyone. Equity, or health equity, or the lack thereof, has been really underscored by the pandemic. So what are the implications of the Medicaid unwinding for health equity? Jesse, you kind of touched on this, if you want to expand on that a little bit.
Sure, I can start, and I'm sure other people have thoughts. Yeah, I mean, I think, at sort of just a high level, kind of that last slide I presented, right? A larger amount of many communities of color are on Medicaid, particularly in the adult population. More redeterminations will be happening. There is potential for greater coverage loss. Jennifer touched on, I think, what may have been the Assistant Secretary for Planning and Evaluation's analysis of maybe 15 million people could lose coverage. Nearly half of those are projected to be Black and Latino. A disproportionate amount of those, I believe, were projected to be sort of churn type scenarios where they weren't actually ineligible, but they were disenrolled anyway. So it has really massive equity implications, I think. And the data that I presented showed, in large part, this provision has clearly helped kind of stop disparities from growing during the pandemic. And so once it's gone away, I think just sort of intuitively, there's a concern that sort of the reverse can happen, that sort of this sort of mechanism that was in place to kind of prevent this is no longer there, and we may see gaps widening again. I think it's really concerning, and I think hopefully it stays top of mind as states start reporting this data, because it should.
Who else wants to touch on the equity issue?
Sure. So Medicaid renewals in general are a story of administrative burden. Are states choosing to increase or decrease that burden, and who are they placing it on? And we know that administrative burdens fall disproportionately on people of color, as Jesse mentioned, because of their overrepresentation in programs like Medicaid, as well as factors like historic discrimination that have led to much more part-time work. Or things with unstable or variable income, which is harder to demonstrate to a Medicaid agency, considering the rigor of verifications that they require. And so we do anticipate this falling disproportionately on people of color because of these high administrative burdens. Then you factor in issues like language and cultural competency and things like that. We're watching closely for what the differences in wait time is in a call center. If you press 1 for English, if you press 2 for Spanish. We are seeing really lack of translations into other languages for notices and key information, or really poor, misleading translations. And so fortunately, many states and communities have really great organizations that help people, the more vulnerable population, walk through that process, but we shouldn't have to outsource it to unfunded individuals in the community, and we need to do a better job. So, 90% of the time I spend panicking about unwinding and what's going to happen, but there is about 10% that's, gives me some hope. Again, these are not new issues. This is not a new program. This is not a new process related to unwinding. It's been happening for a long time, but it hasn't got the level of attention it's getting right now. People are paying more attention to it. People are looking at the data. Some states are posting data, not only posting data about disenrollments, but disaggregating by race and ethnicity. Obviously, it's limited to how their data is actually represented and if they've got accurate information, but we're going to be able to see disparate impacts. We're going to see if procedural terminations, people who didn't get the form or return it, if that's happening disproportionately across different ethnic groups. And it's going to bring a lot of things that have been kind of endemic to Medicaid for many years. It's going to bring it to light, and hopefully we can translate that into action and build a better program going forward.
Dr. Churchwell, Thomas, you want to talk about health equity?
Yeah, I mean, the utilization of the financial resources through this program is more than just the taking care of patients within the hospital structure or actually prescriptions. It's really has been used, I think, in many organizations and in many health systems to define and actually evaluate and think towards opportunities to take care of the social terms of health, whether it be the transportation issues, whether it be opportunities to think through how do we develop plans and processes for a hospital at home or health at home for significant follow-up, and also care not only within the hospital itself, but also before they come and after and post-hospitalization. So the loss of that actually, and the loss of that ability to do that is going to have I think can have a significant impact in terms of the progress we have made within that equity and health equity environment during the pandemic.
Yeah. And from on the health equity, I agree. It has significant impact to the health equity. And actually, I hear the story every day from my team who on the phone and help on membership. And we have very diverse membership. And the team share a lot of story about the minority population. There are a lot more confusion. They have more question. The form is confusing to them because the way it gets translated, Jen, that you mentioned, it's longer, right? So when it translates into a different language, it's longer, and it create more confusion as well. So that definitely will impact the gap. Imagine that if the lack of assistance to help the population going through the process, likely that population may fall off the Medicaid eligibility faster than the other group. And most of many Medicaid member, they may not pay attention to the renewal, that when the day of the surgery, the day of the treatment, and then they find out that they're not active, they don't have eligibility. That will impact the level of care and the impact at insignificant proportion for the minority group. So I agree with you. This have a definitely impact on the health equity side.
Well, I have an audience question for you. Is what Inland Empire Health doing to outreach for members and supporting processing of renewals typical of efforts across California, across health plans? Is there an opportunity for plans in California to share strategies and what's working? I know there is a California Association of Health Plans. I imagine this would be an important topic for you to share best practices with.
Yes, and actually we are very fortunate and grateful for opportunity where the Department of Healthcare Services, they invite us to share our module with all the health plan CEO, commercial, the private, not-for-profit across California. So we shared that forum. We also share the forum that's created by sponsored by the Health Plan Association, the CAP, the LHBC. We share our best practice, the module, to ITUP forum. So many forum that we share our module. So if you're interested, feel free to just send me an email, and I'm happy to share the formula with you. Because our goal is to keep as many health members to renew their Medicaid eligibility.
I feel like in some ways this is sort of the reverse of the Affordable Care Act, when it was in everybody's interest to get as many people signed up. How hard is it to convince everyone, all of the important stakeholders, that it's just as important to keep people signed up as it was to get them signed up when the ACA started? I mean, you're obviously talking about people that you're dealing with who are head and shoulders into this, but I imagine there are a lot of people who are intimately affected by this, who are not the patients themselves, who could still be informed and helped to help those people. That's for anybody who wants to jump in.
Agree, Julie. Acquisition cost is always higher than the retention cost. And also acquisition, the attract sign up people, you don't know who they are. And then you spend a lot of time try to get them sign up. The renewal side, you know who your member are. And it requires unintentional outreach and communication to target those members and get them to renew. And they so grateful when we call them. They just every single call, it just the team share all the story. It's just every single call they appreciate so much, because what happened in the last 3 years, they don't do anything, and they didn't do anything, and they still keep their eligibility. So it's the new behavior that they learned, right? So we have to undo that behavior and reteaching them, going back to the annual redetermination requirement.
So we're getting ready to wrap up, but I want to sort of let each of you have sort of a closing thought. And I want to ask you this, is there a silver lining to any of this? Jennifer, you sort of suggested that maybe we're going to see data that we wouldn't otherwise have seen, and, you know, will give us an idea of how to do things a little bit differently. So let's go around and take a minute or two to make sure that you've told everybody exactly what you want to. Jennifer, why don't we start with you?
Sure. Just build in what I mentioned earlier. There are these needs in the program. There are these flaws in the program that have been there for a long time, but kind of sat under the radar. And so states are paying more attention to them due to the workload. The understaffing is a huge problem, but will that finally push reticent states towards streamlining? Again, the policy is there to make this a much more efficient program that keeps eligible people enrolled. And so people are paying more attention to it before. And I think some states are going to collapse a little bit. One good thing that distinguishes this opportunity from the Affordable Care Act enrollment and the kind of retention versus acquisition is if states do go off the rails, there's an opportunity to stop certain terminations. In ACA, when states were struggling to enroll people, you couldn't mechanically just put everybody on. That required a lot of kind of time entry and paperwork that wasn't possible to do. But now we do have this kind of fail-safe that if states are really struggling, we could stop procedural terminations. And in general, a lot of these best practices that are going to help us through unwinding will hopefully persist in the program and make it better going forward.
Great. Jesse.
Yeah, just to maybe build on what I presented at the start, I think if we think about this over the last 8 or 10 years, we've seen such an improvement in coverage. We've seen improvement in inequities, and we've now kind of come to this point where we're at a real kind of intersection and an event that could really disrupt this. So I think it's just going to be so vital to see the data Jennifer's talking about, and to kind of see the commitment of policymakers to, is it going to build on that, or is it going to sort of be a backtracking? And I think that's a really important question right now. And on top of all of that are kind of the equity considerations that we talked about. So, we're, and as Dr. Churchwell, I think, touched on earlier, we know what happens when people don't have coverage. We know when they go to get care and don't have coverage. We know the effects of that. We know that leads to medical debt. We know that leads to poor outcomes. This is a real, the consequences are really significant for these kind of seemingly minor individual interactions. So hopefully it stays top of mind, and as the data comes in and the need to course correct or change policies happens, we're really hopeful that that occurs.
Thomas?
So the word for today for me, the partnership. So for this minute, healthcare is local. Eligibility is local. So partnership with county is the key. That will, align the strategy with the county, align the messaging with the county, get the data sharing with the county, and get a real-time data sharing. Because any day, I know exactly who's our member already submitted an application. Because with the partnership with the county that allow us to have that insight about our membership, and partnership with the county, partnership with the provider, partnership with the hospital, partnership with the community, it will drive the result, accelerate the result faster.
Dr. Churchwell.
So I jump on the fact that there's a tremendous amount of data now that we've been able to accumulate that can and will probably point towards the fact that with this investment, we had the trend towards a healthier community in terms of overall risk reduction for cardiovascular disease and stroke disease, hopefully. But also a trend towards actually, although the cost was there, we actually decreased the amount we were actually paying out, given the decreasing complication rate, and actually moving towards a healthier community. I think that could actually spur us to actually think about the next evolution of how we need to deliver not only care, but also how do we pay for care? Because we can save money if we pay for care. If we actually make an investment in each and every life in a way that allows us to actually have them to have the resources they need to support themselves within the community that they live, from a medical standpoint and from a social standpoint, we will improve care. And it will actually lead to a decrease in overall cost.
Well, Thank you very much, panel. I've learned a lot in the last hour. I am sure our audience has too. We would love your feedback, audience. There is a link in the chat. Please click on it and let us know what you thought of this webinar. The slides from the presentation will be made available on the Value and Innovation Forum website, along with other resources and articles mentioned here. The webinar recording will also be made available. Thank you all for participating in this briefing today and joining the conversation on this very timely and important topic. Please continue to look out for upcoming briefings and feel free to suggest topics that would be of interest to our diverse audience. Thank you all again.